Hello, future PTAs. Hope you guys are doing well. Today, we're going to talk about architectural barriers, community reintegration, and return to function. So, with community reintegration, what we're talking about is reestablishing pre-existing roles, relationships, including vocational, where they worked, social, community engagement, patients once they go back to community living, especially if they're independent or modified independent, they may need counseling, more caregiver assistance. They may need some mentoring, some support groups in order to successfully reintegrate. When you are looking at sending someone back to work or to social events or whatever, that environment, you need to consider the accessibility of the environment. So if there's accessible transportation, if the buildings are accessible, if there's accessible parking or curbs that are in the way of getting from the parking lot to the building, if there's accessible bathrooms, if there's wheelchair accessible seating, if the aisles are wide enough, if the merchandise height is at the right level. There's so many things to consider, especially when you're using wheelchair mobility, when you're going to a work environment or to a social engagement um, with community reintegration. So assessment tools, there's a lot of different assessment tools that are typically used with people after a stroke, after a brain injury, after a spinal cord injury to determine if they are ready to return to the community and how much assistance they'll need. So there's a community integration questionnaire that looks at home integration, social integration, and productive activities. There's community integration measure, Craig handicap assessment and reporting technique, reintegration to normal living, and the Sydney psychosocial reintegration scale. With our home assessment, what we're looking at there is how safe they'll be returning to their home environment. So we look at a million things, not a million, but a lot of things. We look at their lighting. Is the lighting, is it well lit? Do they have to walk deep into a room before they can reach the light switch? If they get up at night, is there, a night light that automatically turns on or when it stays on, or is it too dim and they're at a higher fall risk? We look at the flooring, the tread. Is it a slick floor or is it one that could easily trip someone? The area rugs, how thick they are, where they're placed. Ideally, you want to remove area rugs. Some people are completely against that. We look at, are there uneven areas? Are there steps up or down that aren't obvious? What is the color contrast? Are the floors busy and hard to, see? Some of the floors, I have a picture later, just kind of do mind tricks on you. They're so busy. What is the color contrast? Are the floors slick anywhere? You want to look at caregiver assistance, how much assistance they have once they return home. Is the caregiver capable? Is it, they're returning home to their husband who is elderly and also has as many issues as, physical impairments as them? Or do they have, someone who is capable of helping them get up if they were to fall? You want to watch them transfer. So toilet transfer, shower transfer, on and off the couch or the bed, wherever they are, especially if you are at their house doing that home assessment. One of the assessment tools we use in home health is called the OASIS. Usually a PT, a OT, or a nurse will fill that out. And they're primarily looking at uh, the fall risk if a patient has a high risk of falls and keeping that in mind. You also want to look at handrails going up and down stairs or in and out of the shower. If there's grab bars, you want to look at the countertop height and if it's at the right level where they can use it to support themselves or hold on while they're, using another hand to cook. You want to look at the doors. Do they swing in or out? So you know how to practice those types of things with the patient. Is the knob on the left or the right? Are the thresholds high? Do you have to practice stepping over, getting the walker over that or something like that? The doors, we just talked about the furniture arrangement, the electric outlets, their accessibility, if there's cords in the way that they have to either step over or that should be moved. The assistive device, Do they fit through the doorways? Do they fit in the hallways and the stairwells? Are there certain rooms, like the bathroom, oftentimes that they can't even use their assistive device in? Should they have maybe a cane or something in there, or are there counters they can hold on to when they walk in there? You want to look at their gait and their balance in different areas of their house, if possible. Look at their medications and make sure they're independent with using those medications. Typically, we'll just refer them to someone else rather than really adjusting. We don't adjust anything, but we really don't even educate them on how to properly take them. We just kind of ask them if they know how, and then refer them on out. Do they have smoke detectors? Is there a lot of clutter? Is there things that can be removed and placed in boxes in the garage or something in the meantime? Make sure that the furniture isn't overcrowded, that there aren't pets in the way, what family members are present, who is helpful, who's more so in the way. Shelf height, the entrance of the house. Do they have to go up and down stairs to get in the house? Do they need a wheelchair ramp? There are so many things when somebody is returning home that you really have to consider so that you can practice them and prepare them, or so that you can help them find a solution to the issue, by building a ramp or placing grab bars, or by getting a, more narrow assistive device. All these things can help somebody become more independent and not risk falling in their home environment and going right back into a facility. One thing to keep in mind is if the patient is bariatric, if they are overweight, then most likely their adaptive equipment is going to be more wide, and so it will be more difficult for them to fit through the doorways, and they'll need more room in the home between furniture and things like that. So keep in mind, when you're assessing their home environment. All right, so this is a before and after. In these pictures, just kind of an example, they removed the throw rugs, which would have definitely been a fall risk. They opened up the floor space to allow for the area for the walker to fit in. They decluttered the areas. Ideally, I would not have the coffee table here in that second picture, because although they switched the type of coffee table so you could put clutter inside, it's still in the way. You can't like walk into the couch with your assistive device. So I would at least move it over so there's one seat on the couch that they can get to without needing to release their assistive device, especially if they're using a walker specifically. All right, so now we're going to go into some of the adaptive equipment that can be used. So a shower chair or a tub bench. Shower chair, you still have to like step over the tub unless it's just a walk-in shower. The tub bench, you can sit on the edge of it and then slide in and then lift your legs over. So sometimes that will help with somebody who has a higher fall risk or more leg weakness. Bedside commode can be helpful so they don't have to travel to the bathroom at night, especially maybe they're sleeping in the living room on the couch, or the bathroom's, on the other side of the house. That can help. A raised toilet seat could go just directly on top of their toilet so that they don't have to sit so low. It also has the hand rails on the side so that you can push up and use your arms to get on and off the toilet. Hospital bed is sometimes placed into a home if needed. Sometimes insurance will pay for that, especially if it's a rental. Sometimes it will not. A lift recliner can be used to help somebody that's just having trouble getting up and down out of their chairs. A wheelchair ramp can be placed. Sometimes there are those like the one in the picture that are just placed over top of the stairs. Sometimes people will have someone come and build a ramp. Placing a handrail where there wasn't one can be really helpful. When we're talking about a ramp, we've talked about this before. The ramp rise should be 1 inch of rise for every foot of length. So for every 12 inches of length, there's 1 inch of rise. Every foot of length, there's 1 inch of rise. So it does not need to be to rise more quickly than that, or else it's too difficult to push the patient up. Chairlift is a good thing when they work. The only problem is I've had a lot of patients complain that it stopped working and the motor stopped while they were in the middle of the stairs. And then you're kind of in a predicament because you don't have your assistive device and you're in the middle of the stairs. But when possible, when they do work, they can help with getting people up and down stairs that otherwise have difficulty with that. A wheelchair lift can be put in somebody's home. It's almost like an elevator. You roll the wheelchair onto and then press a button to lift it higher so that you can go into your home if there's a lot of stairs to enter the home. Here is one of those floors that I was talking about. A pattern like that on a floor could just make anybody dizzy, and it would be really put somebody at a high risk of fall. So in a situation like that, you might want to actually cover it with a very, thin rug when possible, or you may want to just recommend a different flooring, and that's really expensive and would be hard to change. But if there are stairs or even just rises, random place where the floor is uneven, putting colored tape on that is a great way to, help draw the eyes to that area and alert the patient that they need to step up or down so that they don't fall over those. Work reintegration. So one of the things that we use as PTs for work reintegration is a functional capacity evaluation. It's an FCE. That's what we call it. It evaluates the patient's ability to participate in work tasks. So it's a comprehensive performance-based test that's used to determine the ability to work and perform daily activities. You use different components to determine if the patient is able to meet their job demands. Physical and cognitive components. Most of what we are doing here is physical. It can include lifting, carrying, pushing, pulling, how long they tolerate positions like standing or sitting, how long they're able to walk before they need to sit, if they're able to kneel or crouch or crawl or manipulate objects, their grip strength, their grasping, their manipulation of objects. All of that is looked at based on their job task and what they need to do so that we can make a report to recommend whether or not they can go back light duty or full duty, if they're going to go back, no more than this many hours a day, or, what our recommendation is. Now, whether their employer is willing to do that or not is a whole different thing, but we will make our recommendation based on that. We monitor their pain throughout. Most of these take like 4 to 6 hours to complete. Sometimes they'll split them over 2 days, but you really don't get a good enough idea if a person can work an 8-hour day if you've tested them 2 hours on one day and 2 hours on another day. So ideally, you do it all in one day when possible. And then they look at that report to determine if they're capable of going back to work. Some of the barriers to going back into the community. Some people may have memory deficits, impaired attention or concentration, impulsivity, disinhibition, personality or mood changes, depression and anxiety, fatigue. We've talked about all these things, and they're very common with people who've had strokes or brain injuries, even spinal cord injuries. So it's something to really consider when they're going back to their prior life, because it may change everything. Caregiver support, changes in ability and function not only impacts the patient, but also their caregiver. It's a big burden of care. And so sometimes the caregiver gets overwhelmed or depressed. My life looks so much different now, and I don't know how to deal with it. And so a lot of times they need some support too. They need us to direct them to some services, or to train them better so that, they're not hurting their back every time they're helping their loved one move from here to there. They may need, more actual physical assistance, maybe a home health aide, maybe, a nurse coming to the home. Community support groups are good. Emotional support and counseling is good. Financial support, maybe they, need a social work to come in and show them what resources are available in their community to help them deal with this new ailment in their life. Self-care, so adaptive equipment can be used to help the patient become as independent as possible. Caregiver training, you want to make sure they don't get injured, because then they don't have a caregiver. So getting them, as safe as possible, setting up the environment, getting adaptive equipment like the one shown to help them get a sock on or to help them pull their pants up. There's little graspers where you can reach things. There's so many different things. A home health aid is good. If somebody is eligible for home health services, then that home health aid can come a certain amount of times to help with dressing or showering or, any type of ADLs that they need help with. When we are talking about ergonomics, we're talking about a person's efficiency in their work environment, their ability to set up the environment to be most efficient, but also let the least stress or strain on their body. So, for someone who has a desk job, you want their eyes to be about the top of their screen. In the picture, the computer's a little too low. You want their arms to be rested by their side, and then their hands straight in front of their forearms, so their elbows at like a 90-degree angle, shoulders relax. Some lumbar support in the chair. The screen needs to be between 18 and 28 inches from their face. The feet level on the floor with the hips and the knees and the ankles all at 90 degrees, with each of them being supported, and with the chair not being so deep that it's pressing into the back of their knee or their calf. So now we have a lot of the stand-up desk and a lot of other options that can help people, really have good ergonomics while they're at work without having to sit all day, which is really helpful too. All right, that is all for us for the architectural barriers. So if you have questions, let me know, and I will see you in the next lecture.